Welcome to New York City and VEITH 2022. I can tell you what a great feeling it is to be back here. The buzz, the vibe, the crowd, great to be back. This is a highlight of me for VEITH. I am here with the 3 national principal investigators for one of the most impactful National Institutes of Health sponsored vascular trials in my career, the BEST CLI trial. This data was released at the American Heart Association just within the last week or so, published in the New England Journal of Medicine, and we are now going to go into what did we actually learn from this trial. Let me start off with my colleague, Matt Menard. Matt, first of all, congratulations. This has been a real labor of love for you. Give us some background, Matt. How did you guys come up with this trial design, and what was it that you wanted to answer by doing this trial?
So, Alik Farber and I trained together in Boston in general surgery. We both feel fortunate to have kind of emerged from our training at a time when both endovascular and open surgery were prevalent. Endovascular was becoming more and more in vogue. I came out of fellowship, did an awful lot of endovascular therapy for tough patients, and we were talking at a regional vascular surgical meeting, and we both shared this sense of the medical term for it is equipoise. We both really realized that we were struggling with knowing what the best thing to do is for a whole cohort of patients, those with tough perfusion to the feet, so critical limb ischemia patients. So ultimately we cooked up this, at the time seemed kind of a harebrained idea to have a clinical trial. Fortunate for us, it was a clinical question that all sorts of folks agreed was of very high importance, so huge amount of equipoise. Ultimately, we applied to the NIH, was very fortunate to get funded. But the trial has been kind of, highlighted by just the enormous amount of support we've had from all the surgical societies, all the medical societies that we've partnered with. It's been tough, there's no question, it's been a challenging study to undertake. But throughout the whole journey, it's been, earmarked by a clinical question that hasn't really changed. It's as relevant today as it was in 2007 when we had that very first conversation.
So that's a great story. Alik, great to see you. Congratulations. You must have a great sense of accomplishment for having this been completed. But let me ask you, so now the trial's done. I will admit I've been honored to follow along on this journey with you guys in a supportive role. And I read the paper and I followed the data, and it's complicated. So can you tell us, what's the blockbuster story? Like, what did we learn from this trial now that we have the data out there?
Well, thank you, Michael. That's certainly an important question to answer. I do want to say that this landmark trial was designed by a multidisciplinary group of experts that represented interventional cardiology, vascular medicine, radiology, and vascular surgery. We got together and we tried to organize the best possible trial in the very complex space that the CLI is a part of. This trial really is a combination of 2 parallel trials. Because saphenous vein outperforms other conduits, we felt that we really needed to study it separately. So in cohort 1, or one part of the trial, we compared patients who had adequate single segment saphenous vein against endovascular therapy. And in cohort 2, that included patients who did not have single-segment saphenous vein, so if randomized to surgery, any conduit could be used, including prosthetic. And then those patients were, in both cohorts, were stratified by whether or not they had ischemic rest pain alone or tissue loss, and whether or not they had tibial disease or not, and then randomized 1-to-1 to either endovascular therapy or surgery, and we allowed the investigators to use any techniques that they typically use in their clinical practice. So as such, this was a pragmatic trial. And the results of cohort 1 and cohort 2 were not pooled because we view these really as 2 separate trials. So what we found was, number 1, both endovascular therapy and surgical bypass work well. They are effective and they're safe. Number 2, that in patients in cohort 1 who were candidates, judged to be candidates for both open surgery and endovascular therapy, those patients with good vein, bypass with good vein, outperformed endovascular therapy in that there was a 32% reduction in primary outcome of major adverse limb event and or all-cause death, and there was a 27% reduction in amputation rates. and a significantly higher rate of major interventions in the endovascular group. We learned that the safety of both surgery and endovascular was actually quite good. They were similar at 30 days when you look at death and major adverse cardiovascular events and over the course of the trial. So both are safe to do. And then lastly, in cohort 2, where patients did not have good vein, the results of cohort 2 is actually quite similar between open and endovascular. And so the conclusion from this is that, we have a number of arrows in our quiver, and we have, medical therapy, endovascular therapy, and vascular surgery, and there are other things that are coming down the road, cell-based therapies, and we are just trying to define the position of each of these treatment strategies, and I think Best CLI is a first step in sort of defining a little bit more than we have about what works best for home.
That's fabulous. Thank you. Ken Rosenfield, first, let me ask you, what got you interested to be a principal investigator in this trial? What was it about the trial and the concept and the question that got you included?
Thanks, Michael. Great question. First of all, I was lucky enough to be invited to participate in the trial to encourage a multidisciplinary team-based approach, and in fact, the concept of the CLI team was really pushed by all of us during the conduct of the trial. As far as the opportunity to participate in this kind of a monumental landmark trial, I mean, who would turn this down? A great opportunity to actually define level 1 evidence in a space where there really is very, very little, as opposed to, for example, the neurologic community and the cardiology community. We, in the vascular space, really need to do more like this. And this is a fundamental question that I think all of us need to answer when we face an individual patient in our offices. What should I do with this patient? Given the angiograph information I have, the knowledge of what conduits they might have, and so on, it's a great question that we face every day.
Fabulous, and of course you've been involved in many other NIH vascular trials, so this is right up your alley. So now that the data is out, and you've had a chance to digest it and talk to some of your colleagues once the paper and the data was presented and published. First of all, tell me what we as a community learned as a result of this that we didn't know before the results were available.
To answer that question, I think we learned that, number one, endovascular first is not the right thing for every patient and every situation. That in some circumstances, it's clear that surgery is a better treatment option as the first approach. Second thing we learned is that both endo and surgery are durable. I think it's important to know that the endovascular approach is durable, and that has also been questioned. The third thing I think we learned is that it's important to conduct these kinds of clinical trials and participate and contribute. We learned how difficult it is to do that. It's very challenging to randomize somebody between a less invasive strategy and a very aggressive strategy or a more invasive strategy. The big question is how we're going to interpret this, and you asked me about my colleagues. It's obviously very controversial. There are people who feel passionately about endo, and there are people who feel passionately about open surgery. And I think as we unpack the trial a little bit more, we'll learn about what were the types of patients enrolled in the trial, how complex was their disease versus not, and that will help us define better who's right for endo and who's right for surgery.
And as we all now move forward from here, obviously the question is, what happens to the practice of vascular disease care in people who specialize in managing patients with critical limb-threatening ischemia? And so I'll start with you, Matt. What's your prediction? What's going to happen in the near to midterm as a result of, let's say, cohort 1 in Best CLI?
It's a great question. I think time will tell the answer to that question. There's no question there's been a move away from surgery in the last 10 to 15 years. And so I think this trial result is going to really push the surgical community to take a look at that and really, make sure that the ability to do a good, high-quality surgical bypass is not lost, and it becomes, once again, a standard part of training and practice. For the endovascular community, I mean, one of the big messages is, endovascular therapy is not going anywhere. It's a huge part of what we do. Alik and I do both. Kenny does lots of high-end endovascular surgery, but we have to focus on the patient. So for a given patient, what is going to be the best treatment for that patient? And if you are an endovascular therapist, I think it's incumbent on you to really partner up with a surgeon. Find a surgeon that you trust and can work with, and work together to figure out, which therapy is. So it's exactly like a medical oncologist and a radiation oncologist and a surgical oncologist. No different. They're not competing, but they're working together for the benefit of the patient. So I see that as paramount, and I also really want the whole community to get beyond open versus endo. I think that's really, we're guilty because we just did a trial comparing the two, but I think it's imperative that we kind of move beyond that paradigm and just figure out for a given patient, when you might use what, and 10 to 15 years down the line, hopefully we can be as granular as the cardiology world, where we know very specifically this patient with renal failure and diabetes with this particular anatomy, this is the best first step, and these are the medications they should be on, and these are the follow-up, things you should be thinking about. That's sort of how I envision it.
So in the last few minutes, I'm going to ask you guys a couple of quick hit questions. You just got to spit out the answers as fast as you can. You ready?
Ready.
Okay. So I've heard, since you presented the data and it came out in the New England Journal, a couple of criticisms. So let me ask you one. 85% immediate technical success rate with an endo case. People say that that's not reflective of modern practice of endovascular therapy for below-the-knee CLI. How do you respond to that?
I say that that's not really true. There are a number of papers in the literature that looks at difficult endo, and the numbers of technical failure there approaches between 10 to 15%. A lot of the trials that we're used to seeing in endo relate to industry trials where if the lesion has not been crossed, those patients were not included. So I actually think this is probably related to what the reality is when you're dealing with difficult endovascular occlusive disease.
Ken, there have been some criticisms about the fact that a significant proportion of patients randomized to endo did not receive actually what's considered to be state-of-the-art endovascular treatment. How do you respond to that?
Well, first of all, I would say that endo is a moving target. A little unlike surgery, where there are standards of practice that are sort of accepted in there, and the way to do the bypass is generally pretty standardized, from my understanding. The endo world, there was much more variation in treatment in the endo arm, and that's probably reflective of the practices of the people who were enrolled in the trial. There is a question of, this is real world, I guess. It's what people out there are doing, and there is variation. So I can't answer that beyond that. We have to, again, unravel the data a little bit and see.
I think we tried hard. Any trial has to figure out who are the investigators and what's the benchmark for entry into the trial. And we very much wanted it to be a real-world trial where folks that are doing critical limb care, in routine part of their practice from all specialties, radiology, cardiology, and surgery, were participants in the trial. And so to some extent you could say, our trial reflects what's, just as someone earlier said, it reflects what's being done in the community. So that's just important to keep in mind.
As we wrap up here, one of the really exciting parts to me of Best CLI is how well you designed, the three of you, future data releases, other aspects of things we're going to learn. Give me a sense, Alik, what can we look forward to learning as more data comes out about Best CLI?
Well, Michael, we're fortunate to have had the Novo Nordisk Foundation invest into Best CLI, and as such, we're going to have the resources to be able to not only collect angiographic and cross-sectional imaging data from all the sites and the patients to really evaluate the occlusive nature of the disease that these patients had, but also we're going to have a very organized approach of asking the right questions from this data set and coming up with a treasure trove of data that's going to hopefully inform how physicians who treat CLI take care of their patients. So we're really looking forward to that.
Coming from VEITH, with all the excitement and buzz around this, it's worth taking a moment for me to personally congratulate you, Matt, Menard, Alik Farber, Ken Rosenfield, for making this trial come to its conclusion. This is in no way easy. You guys have been absolutely phenomenal. I'm thrilled to see how more of this comes out.